this episode of the Unapologetic MidLife Podcast, Mindy welcomes Dr. Nina Strollo, who is a board-certified OB/GYN and who has been in practice for over 15 years. She started her medical training at SUNY Upstate in Syracuse and followed with completing her medical residency at the University of Buffalo. She's a proud owner and partner of Suburban Women's Healthcare. During the course of her practice, Dr. Strollo has been passionate about adolescent health, family planning, contraception practices, and over time, she has grown interested in perimenopause and menopause. Welcome to the Unapologetic MidLife Podcast. I'm your host, Mindy Labazetta, and I am here today with a special guest, Dr. Nina Strollo, who is a Buffalo-born OB/GYN who's been in the field for over 15 years. Welcome, Nina.
Thank you. Thanks for having me.
Thank you for being here. I am so excited to have you on here because, as you know, and I know we've had a brief conversation, perimenopause, menopause, everything women's wellness for this phase of life is literally all the rage right now. And I feel like
blowing up.
Rightfully so.
No, I talk about it all day.
Okay, perfect.
Yeah.
So let's talk about this. So you've been an OB/GYN, but you're kind of taking this dive into women's wellness beyond fertility.
Yeah.
Where did that come from?
So the huge part of our practice was OB for so long. And I joke now that when I first started, when I came out as an attending, if I would talk about menopause with people and try to get them on hormone replacement therapy, they would look at me like I was committing malpractice. So finally, I think, thankfully, which I'm generally not thankful to social media for a lot of things, but social media has blown up the space of perimenopause and menopause and re-examining the literature that we knew was sort of, put out incorrectly and scared women from not being treated for the last couple decades. So now I can finally practice what I learned in residency and see women in real time get relief from so much of what they're going through. So it's a good time to be practicing and having a specialty in perimenopause and menopause.
Yeah. And honestly, I have a full-time private practice and I get a lot of women who come to me. My favorites are that woman who's 40-ish, who feels like she's losing her mind and is ready to literally have like a mental breakdown. And I get very excited because I'm like, I have a lot of information for you. And a doctor like yourself who is like, okay, I get this. We're not just going to tell you your labs are fine and send you on your way.
Yeah.
What does this look like for you? What are you seeing most in your practice?
I think that's one of the biggest things, right? Is because, not only are our 40s difficult just with life, jobs, kids, all of the things, but then you add on to all of this hormonal stressors and it's just a powder keg basically waiting to explode. So again, 20 years ago, you would try to talk to people like, hey, let's get those hormones, more regulated, and no one wanted to hear it. And now people are like, please, please, please help me.
Yeah. Do you feel like we're still I feel like it hasn't kind of caught up like supply and demand, right? There's a shortage of doctors who are on board with this, and I still see it from clients.
It's bizarre to me. It is so bizarre because even here we have a small community, so I know a lot of other practitioners, and people will come to me from other providers and say like, "Oh, they told me I'm too young for this, or I can't do." And it again is just sad existing amongst them and existing with the same information that we had 20 years ago that again was inaccurately put out. And then it isn't new.
It's not new.
It isn't new. And so it is weird that we still have barriers to care. So yeah, I mean, it's exciting because truly it is one of the most satisfying things to start someone on hormone replacement therapy and watch them come in and be like, my life is changed.
Yeah. I literally posted, I follow a bunch of those doctors online, and I posted, somebody was commenting about like, not all estradiol patches are made the same. And I'm like, for the love of God, stop fucking changing all of our prescription manufacturers because I'm going to lose my mind.
Well, and now with the shortage too, it's like trying to get people to get the equivalents of gels and all that other stuff. But I'm just happy we're starting.
Right? Yes. Because the conversation's out there. Yes.
This conversation is out there and people are listening. So
yeah. It's just wild. Now, you mentioned women in their 40s, but what age can this start at? I mean, if a woman's in her 30s,
Yeah.
right?
So simplistically, if we just consider perimenopause being changing, dropping hormones, right?
Mm-hmm.
It can start as early as 35. I mean, it can start even earlier pathologically.
Yeah.
But for women, we know that stuff changes after 35.
Yeah.
40, maybe a little bit more common. 45, we're all going through some sort of change.
Yep.
So, and it could be changing for a little bit, then go back to normal for a few years. And so I think perimenopause is actually, sorry for all the women that are in menopause,
The
but
fucking
I
worst.
think it might be more difficult with the ups and downs and and not knowing what to expect. At least in menopause, your hormone levels have dropped. You're kind of on equal playing fields. Perimenopause is different every single day, which is why labs are difficult to use as a determinant of whether or not you should be treated. So,
And there's not a lab, right? It's like, oh, we've done this lab work and you're in perimenopause.
right.
No,
Right.
but
It's clinical. It's all
it's
clinically
clinical.
based. And there's some nuance to that, right? Like, so if someone's had a hysterectomy or so, there are some questions of, is it heading into that space? But at the same time, it's all clinically diagnosed and then treated.
So when you
So
say
you don't have to
clinically,
get labs, especially in
okay,
today's space where insurance, charges so much money
$1
for
million for
lab
everything.
work. Yeah, exactly.
But there are times where lab work would be beneficial.
I think, again, nuanced, right? So
Okay.
sometimes people are like, I just want to know where I stand right now. I want to know, maybe we're talking about using testosterone. That could
Mm-hmm.
be beneficial. Someone's had a hysterectomy. They don't know if they're in menopause because they don't have their period as an indicator. And so basically it can rule it in if it's, if your FSH levels are high, but it doesn't mean that if it looks normal that you're not at least in perimenopause.
Yeah. Yeah. So there's, like you said, it's relevant depending on the situation. Each case, everybody's different. But we're going by, when you say clinical, like how a person's feeling. And I guess, like, what are symptoms, right? Isn't there like over 100 symptoms of perimenopause?
Right. So if you read the symptoms, I think my husband's in perimenopause, right? But at the
Well, they have
same time,
andropause.
yeah, he is in menopause. He isn't. Hot flashes are the big ones. So if you come in
Yeah.
and you tell me you're having hot flashes and you're not sleeping, and that's an obvious one.
Yeah.
Stuff like brain fog, mood disturbances, those are also high on the list there.
Yeah.
But I'm careful because to sell someone too in that HRT is going to be a fix to everything. I don't want to leave out of part of the equation of, hey, do we have a licensed mental health professional in the mix here? Is your relationship in a good place? Is work in a good place? So those symptoms that are a little bit further down on the list have to be taken into consideration. And again, I'm all for hormones in every case, but we have to talk about it being a well-rounded whole treatment picture.
I mean, there's always going to be people who maybe aren't going to be a good candidate for that. But I would say, I mean, I guess you would be the better judge of that, but like, are more women than not benefiting from hormone replacement? Because I also think that there's still a lot of stigma, right? That WHO study that came out in the 80s, like, women are like, nope, can't do that. Or, you get your people who are maybe in the 70s and like, oh yeah, I did that, but I could only do it for 5 years.
Right.
What do you have to say about that?
I think anyone that is interested in trying should try, right?
Yeah.
So if they come in and like I said, if those symptoms that aren't the obvious hot flashes, night sweats, they're a little bit more vague, but we're interested in trying and they're not an absolute contraindication. They don't have a blood clot or something. Let's try it. Let's see what happens. If you get a benefit, great. If not, we stop. And then maybe in a couple of years we retry because maybe that's not where we are right now, but who's to say in a couple of years, that's not a different picture.
Yeah. I think that, people are nervous, and I know women are particularly more sensitive to like medication differences or brands, that kind of stuff. I know I was just mentioning the stop changing my manufacturer. So this is a little bit of trial and error, right? They have to kind of see how they feel.
Absolutely. And the other part of that is you need a provider that's going to say to you before you start, this isn't cut and dry. This isn't black and white. We might not knock it out of the park with the very first thing that we do. And we have to be willing to work together and keep the follow-up happening.
Yep.
And you deserve that as a patient to put prioritize yourself to keep putting that work in too. So
Yeah. I always like to say, like, miracle doesn't happen in a bottle, right? Like, you got to do the hard things. You got to do
yeah.
the work. I know sleep is a big factor, right? If they're getting the hot flashes, you're waking up in a puddle, which is a blast.
No, sleep is huge. And I am, if I don't get enough sleep, I'm a miserable human. And I say to patients, like, your cushion to deal with life just goes away.
Right.
So if after a week, 2 weeks, however long, you haven't slept because you've woken up with hot flashes or you've woken up with anxiety, feeling, that your heart's racing,
Mm-hmm.
how can you, can you be 100% at work? How can you not have brain fog? How can you, so all of those things go hand in.
1000%. Yeah. Now, you mentioned testosterone. Now, is this something that you will work with a patient on if they come in and they have no testosterone? You do hear a lot about, I can't find a doctor who will prescribe me testosterone. So what are your thoughts on that?
Again, I love testosterone. I like it dosed appropriately, right? So
Right.
there are some concerns when we're using them in these super physiologic doses and these high doses that
Right.
women aren't made to have, because those doses, they're going to make you feel great at first, but then you're going to have to keep chasing and chasing and chasing these levels. So used appropriately, it's great. The problem is it's still, it's still a controlled substance, and it's still a pain to write, and it's still, has to go through specialty pharmacies in a lot of cases. We're getting a little bit better about the workarounds through the commercial pharmacies, but no, I
A
think
lot.
it is a lot. But again, for a patient, if they're willing to put the work in, use it, try it, and give it time, I think there's a lot of women that benefit from it.
Yeah, no, I agree. I think there's a lot that go down the route. What are your thoughts on the pellets and stuff that women are doing?
So,
The thought of that makes my skin crawl, but
yeah, so, I'm Western medicine doc. So at the end of the day, we still have, again, even though we talked about the bad studies in the beginning, right?
yeah,
About
because they're there. That's where all the
and we don't get it right always, but we do know that pellets, again, once they're inserted, they're there, and we do see the levels of women, their lab work is wildly 10
insane.
times, 20 times what they're supposed to have in their body. And with testosterone, a lot of those side effects are, they don't go away, and they can be bad. So,
And what are I think people need to know the side effects. Like, what are the side effects if you are doing pellets and you're at a man's level of testosterone? Like, yes, we need all the things, but I'm not trying to be a man, so I don't want man level testosterone. What does that look like?
So you can get permanent voice deepening. That's one of them.
Okay.
You can get cleromegaly. So that's when your clitoris obviously gets bigger than it's supposed to be, and doesn't go away. More concerning for me, we can get cardiac changes that can end up in cardiac muscle dysfunction.
Does that impact the hematocrit in women the way it does in men too?
Yeah.
Okay. Yeah.
Yeah. So there are real concerns associated with those huge doses. But when used
Appropriately.
when used appropriately, we can have a little bit more energy. Maybe a little bit, it changes our libido. Maybe we can have a little bit more energy.
Let's talk about libido, because I feel like we don't talk about this enough, right? Like, women deserve to have a healthy libido through perimenopause. So testosterone is something I've seen that can be prescribed vaginally for assistance with libido, but I don't know if systemic is also helpful.
Yeah. So yes. So it is, but probably we have more research on the medication called Addyi that is out there. It's tough because, unfortunately, that's not generally covered by insurance.
Because libido is for us is not a reason, but they'll prescribe a blue pill for a man for his erection. Okay.
Obviously, who cares? Who cares about the woman not being involved in the situation?
Yeah.
But from your line of work, this is a huge thing that I talk about
this a lot. Yeah.
If you're in a relationship and that relationship has been under some stressors, like one of the best things that you can do is clinical behavioral therapy, right? So working on that and working on the relationship first.
Yeah.
But yes, if you're exhausted and you have no drive at all. Like,
I mean,
we have to come
address
at it
it.
from a couple different
Yeah.
perspectives.
I mean, this isn't like just get slapped on a medication and all your stuff is gone. But say that we'll say a perfect patient, right? Maybe they're getting sleep. Maybe their stress is
Yeah.
managed. Maybe they exercise, maybe they're not on 8 million antidepressants, which also suppresses libido. So maybe they're that ideal client who is doing the things, but libido is still like, see you later. So you said this Addie is an option
Yep.
that could help. Okay.
Addie and daily testosterone gel.
Okay. Okay.
But again, Addie, and there are, I mean, you can work with insurance, and some insurances will cover it, but
Okay.
it is a good medication that I don't think, again, we're not talking about enough.
Yeah. And that's why I want to put it out there because I have not, maybe I've heard of it, but I've definitely not
It's the
heard
little
about it.
pink pill.
It's a little pink pill. Okay.
There was a medication called Vyleesi. It's an injection, good for about 48 hours. So not as, I don't think it's just
Is it, Addie, is that like something you take daily or do you need to take it prior to
take it daily at night.
Okay.
Yeah.
Okay.
So it's a daily medication. But again, if
That's
you're
okay.
struggling,
It's
and
there.
it's there. It's there, and we should talk about it so we know that there are options.
Well, and I know vaginal estrogen, right? That's another one.
Mm-hmm.
I'm going to say it. I've jumped on that bandwagon after a UTI. I've had a hysterectomy. So like no one talked to me about any of this stuff ever. I've had to figure it out the hard way. But what the fuck? Why is every woman over 40 not on this?
They should be. They should be. I mean, honestly.
Post-hysterectomy, I feel like every woman should be on it.
Well,
what are your thoughts on that?
Back to your point, too, just about painful sex or about not wanting sex. If it's painful, who's another reason to not want it? Like if it's dry as a bone and it's uncomfortable and you're just doing it to basically do it, again, that drive is going to continue going down. So yes, everyone, and there are no contraindications to vaginal estrogen. So even women that have had breast cancer or active breast cancer patients, you can be on vaginal estrogen, and you should be on it because you should try to be, as functionally normal as possible.
Well, and I think of this too, like maybe you don't have problems in your relationship. Maybe you're still attracted to your partner.
Of course.
But now it's painful and it feels like shards of glass in there. So this can help you stay connected to your partner.
Exactly.
And it is an important component of a relationship, and to pretend like it's not an issue. When I get women that come to me, I'm like, okay, we have to talk about this and we've got to like go here because.
And I wish they would talk about it more, and again, so I always ask too in my 40, are we having any issues with painful sex? So we put it out there to normalize it so they don't have to come to me to say, hey, this is a problem.
If you're ripping the Band-Aid off, I feel like you're bringing the potential issues that they might be having, but maybe are too embarrassed to bring up in the room, which is really good.
Right.
You're staying ahead of it. Yeah. Yeah. I mean, if UTIs and frequent UTIs can be eliminated by a really cheap medication that's covered by health insurance, there's no reason to not have it on auto refill. For now. I mean, who knows? Big Pharma loves their expensive stuff. But so breast cancer, we've talked about a little bit about cancer, like hysterectomies. But breast cancer, like a lot of women are like, well, I've had breast cancer. I cannot be on HRT. What are their options?
So
and I know there's variables.
Yes. So that is a huge thing, right? So if you are a breast cancer patient, and most of us do, but know your hormone receptor status or your BRCA status, because if you're like a BRCA positive breast cancer patient, you may be still a hormone candidate. So you're not just
they don't know that
out of it because you had breast cancer. If you're an estrogen receptor, progesterone receptor positive, then yes, probably not. We really can't get into that because adding hormones, at least for right now, the conversation might be risk benefit down the road. And this is an evolving conversation. But for right now, we know giving women back estrogen may increase their risk of recurrence. So that being said, if they're suffering with hot flashes, night sweats, we have 2 other medications. Veoza is a big one right now that is being used and can at least help that and help with sleep. We can treat sleep disturbances separately.
Okay.
We can use SSRIs also in addition to those things to help us feel more normal. And vaginal estrogen, like I said, is huge. So breast cancer patients can use vaginal estrogen and should.
They should.
Um,
The amount of women that I've worked with, I've sent women for like aftercare. You've had breast cancer, now you need aftercare to help you manage. You've been thrown into menopause.
yeah.
And they're just kind of like, some of them are just told, nope, sorry, you got to deal with it. And I'm like, this is like,
Awful.
why aren't you on this?
Right. Right.
You know,
Why are you suffering more?
and like you said, I think there's like rolling out the risk, like vaginal estrogen, right? It's my understanding it doesn't raise systemic levels, so it's
Correct.
not absorbing into other areas in the body.
Right, correct. But that being said, we have oncologists in the area, I will say, that may be more coming around.
Okay, good.
But this is not new information. Probably has been out for about 5 years. Very clear that breast cancer patients can be on it. And I would say, let's get on vaginal estrogen. Oncologists be like, absolutely not. And it's like, well, that's not what the research is showing.
Yeah.
A, and we're scientists and we should know that research. But B, if you're still so in oncology land, it's still important for you to see the patient as the patient in front of you. We're not asking you to
Yeah.
do anything that's going to harm them.
Right. And I don't know, like, is it a liability thing? Like, where do you think that fear comes from?
I think oncologists really do see the world differently. I
Okay.
think they see, and again, I don't know. I'm not an oncologist, but I have tried to place myself in their specialty. And I think they just see this disease process as we must do everything to fight the disease. And they a lot of times will not see beyond into the patient themselves. And that's not every oncologist, obviously.
Of course, right. Yep.
But I really do think it's just a different mentality in how they view their science versus a women's health physician that is looking at the big picture and how we have to survive in this world.
Yeah, I mean, I think quality of life, right? Like, I don't want to just survive cancer and then not have a
Right.
quality of life.
Right.
Like, it's
Right. And there's a lot of people that will say I had to, I have a lot of people that have stopped their endocrine therapies, knowing, hopefully fully informed that they may have an increased risk of recurrence, but they say I can't live like this, so I'm not going to continue that.
when you say endocrine therapy, like hormone
So that's like your
suppressing.
tamoxifen or your
Okay.
Femora or
And those have a whole, I mean, I don't know if it's the effects of like forced menopause, but is that suppressing testosterone too in women? Because if it's suppressing the ovaries.
letrozole, yes, because testosterone in women gets converted to estrogen.
Okay.
So again, trying to decrease any estrogen that you have hanging on in your system that may be, I guess, feeding breast cancer cells that are still circulating.
Which is ironic, though. So I don't know, do you ever listen to Dr. Corrine Menn? Or are you familiar with her? I know she's big in the breast cancer world.
Yeah.
Okay. She talks about, like you mentioned, down the road. Like, so if there's some time in between, things have been good. I mean, every cell in your body utilizes estrogen. Why don't they tell men after prostate cancer they can't have testosterone? Like, I mean, I guess there's layers, right? Because I know there's different kinds, but there's complexities when it comes to this. It's not just black and white.
Right. Right. And I think that conversation is being had finally in the sense that, right, our cardiovascular system is suffering. So I do feel like it's going to be an evolving conversation that may help women sort of live a more estrogenized life status post breast cancer. So
But I think this is about giving women the power to choose. Like, here's all the information, here's all the research. You have options. You don't just have to suffer over here because of some terrible, faulty study that scared the crap out of every woman and made them flush all their HRT down the toilet.
right.
It's like there's options now. And I don't feel like, oh my God, HRT's for everybody. But I truly think there's women who are suffering that are just afraid to like take any kind of medication. I've tried to explain to them it's like taking a granular of salt and throwing it at the body. Like, it's that small. It's not birth control, which I know sometimes birth control is used in perimenopause.
Yeah.
I guess,
lower
depending.
dose ones.
Lower dose, yeah. Like if a woman is bleeding constantly.
Yeah.
And that doesn't stop, they would use birth control for that?
So there's a very low dose birth control that also functions as like the highest HRT.
Okay.
And so if I'm trying to get everything taken care of with one medication, I'm going to use that because if I put them on a patch and progesterone, that might worsen bleeding or have them have more irregular bleeding. And I'm kind of a one-stop shop. I don't want to be going, listen,
You're busy.
I only have time for, like, as a patient, I don't want to be dealing with a bunch of things. So for me, if I was seeing myself through their eyes, I don't want to be going on a vacation and worrying about hemorrhaging through my pants. So
yes. Yeah.
not only am I trying to help your mood and your hot flashes, I'm also trying to make you not have to worry about running to the bathroom every, 5 seconds if you get your period.
Because that's horrible. I've heard the horror stories of that. Yeah.
Yeah, it's
I feel like
terrible.
we're at that point where like we don't want that anymore. Like we're good.
No, that like, what just happened?
Yeah. Yeah, exactly. I guess I have a question for you too. So like when we talk about perimenopause, women are having babies later and later in life.
Mm-hmm.
What are you noticing with that? So we got a woman who's maybe in her 40s having a baby, and man, I feel like the struggle train, it's hard for us, let alone without, but that experience.
I know. I think, so from a perimenopause standpoint, to me, yes, they can come back postpartum and sort of already be entering that time in their life with their hormonal changes. But I think one of the biggest things that I see from an obstetric point of view postpartum is going to be those mental health changes that happen thereafter, right? Because having a baby, being postpartum is difficult
already,
no matter what.
Yep.
And now you add in sleep disturbances and being a little bit old. And hormonal changes that I see as, as almost a setup for
a disaster.
Disaster. Yeah. Like, let's get us connected with the mental health specialist in those situations for sure. So yes, they have their babies and then might go right into perimenopause, or the opposite where they think, oh, I'm in perimenopause, I can't get pregnant.
Oh, and then they do.
And then they do. And then it's like, I didn't know this could happen.
A lot of women will say, oh, I'm nursing, I can't get pregnant.
Yes,
and it's like,
yes. That's not how that works.
If you ovulate, you can get pregnant.
It's gonna happen.
And there's no guarantee with that. So, but yeah, I feel like
why too with the HRT with your pads. So that's why we use that low dose birth control a lot too, is because if you are 43, 44, and that maybe things are changing, you're not ovulating regularly.
Yeah.
But we don't have any other birth control on board. We should probably be protected from all points of view.
Are you seeing an influx of women who are afraid of birth control? Because I feel like that's the other flip side of social media a little bit right now too.
You don't want to go there. You don't want me to lose my mind.
Lose your mind. I think people need to hear from doctors instead of a 20-year-old influencer on TikTok.
That's just
like it makes me insane.
Many young. It's the weirdest thing that, right? The perimenopause generation is we're finally getting it. We're like, yeah, hormones are amazing.
They're amazing.
And we were on birth control, good, whatever, but we had control over our bodies. The 20-year-olds, I am like, I'm out of my mind because they don't want, because they're hearing it's bad, because they're hearing they're going to cause infertility, because they're hearing it's going to cause them breast cancer. And
let's talk about our food, right? Infertility, our food, inflammation. There's another whole,
and moving our bodies.
Our bodies.
I mean, we're a much more unhealthy society.
1000%.
And adding a pregnancy, an undesired pregnancy, to that picture because of misinformation just makes me want to rip all of my hair out of my head. So, I mean,
I agree.
I fight
1000%.
I fight this daily. And I'm like, who told you that? Who said that? What? And there's a bunch of options. Let's come up with something that will work for you. It doesn't have to be the pill. But
right, there's copper IUDs. I mean, there's a million options.
Give you any kind of birth control, just don't have an undesired pregnancy.
Well, and I don't know, why aren't these influencers talking about that on TikTok, right? I feel like a little sex ed out there to let people know a little more information on that. The natural way. Okay, well, that's...
I mean, the Oura rings are adorable. Don't get me wrong. I love them. They're very cute. But use condoms then too.
Then you got to use a condom. Yes, yes. But that's the flip side, right? And it's definitely, it's a lot. I feel like it's a lot. So as far as mental health, now, what does that look like in your practice? Are you guys like, nope, we need to refer, we need to connect? It sounds like you have conversations with your patients about this.
Absolutely. And there's another barrier, right? So there's a stigma that I am shocked at still also. From a women's health perspective, that's part of my questions when you're coming in for your annual, or you come to me and you say you've gone through some traumatic life event
Mm-hmm.
outside of perimenopause and other hormonal changes. I say, let's get you connected with someone to talk to. And they're like, no, I'm good. I have my friends, I have my family. And those are
I'm talking
important.
to my boyfriend. Yeah, no, that's not
Yeah.
it. I'm talking to I'm going to say this, my church group, or
Yeah.
I'm like, oh God.
Yeah. Having a social network is important.
It
Obviously,
is.
we want
It
you
is.
to have a good group. However, it is, to me, in this day and age, also wild that we aren't just all connected with some
I tell
therapists.
people my therapist just recently retired, but I was a therapist with a therapist for years. It was great support. It was a great place to put things. Everybody's got stuff. Like nobody's
Yeah,
coming through this world unscathed
abs-
from
and it's a
something.
heavy, heavy world right now, right? So
It is.
everyone's a little bit more angry, a little bit testier. So why wouldn't you just give yourself that space to unleash?
I think this comes back to self-care. And I think some women, some men too, think that they are just going to go through life handling it all. I like to point out to some of my clients who think that they can handle it all. Like, yeah, at 32, I thought I handled it all, working 3 jobs, going to school full time. And then I got sick with my first cancer. And then the second one came 6 months later. So, and slapped me in the face and reminded me who was boss. I don't do that anymore because I can't. But I don't want somebody to get to that point where they're not managing all their stuff and they're overdoing it. So I think self-care is huge for women.
Absolutely. Absolutely. And we don't want patients, friends, other people to have to get slapped in the face with
No.
hey, you need to slow down, right? Life is bigger than you.
Yeah.
So until that happens, and it is good to remind people. And yet you can do a lot of things. Doesn't mean you should be doing a lot of things, right?
I think it's like, or it's the opposite. I got people doing too much. They're managing the house, they're managing everything and everybody's schedule, and they're not taking that walk in the evening or giving themselves the 20 minutes in the morning to work out and lift weights. I mean, that's something that I'm pretty big on, like prescribing to clients is as physical activity.
Yeah.
I mean, you have to see that impacting the hormone world.
Yeah. Yes, yes. And longevity, right?
Oh
If your
God, yeah.
bones are brittle, you're gonna fall and be down for the count for however long. And movement and balance and all of that. There's so much research to say movement is a huge component for longevity and wellness. So
I'm going to say this. I know there's this push for like body positivity, and I'm not saying everybody needs to look the same or be the same size. I'm not saying that at all. But I think that there's a lot to do with like being obese, like to the point where your glucose and your insulin resistant, or, you're dealing with cardiac, or you're dealing with, I don't know, I guess diabetes falls under insulin. I don't know. I feel like the pendulum is starting to swing the other way with all the GLP-1s. What's
agree.
your thought on that?
Well,
Ooh, we're going to dive right in.
yeah. I mean, it's tough, right? Because when I was growing up, there was
Mhm.
not body positivity, and we grew up. My friends and I will joke that the terrible commercials, like the Special K diet and the pinch and inch,
Mhm.
so we were happy to have the body positivity, but yeah,
You had to
now
figure it out a little
but
bit.
we figured it out, but again, it's swung. But I also don't know in terms of what people have access to in terms of healthy food and healthy living and
There's layers.
education in that,
Yeah.
and what how exercise is prioritized in households. And I see unhealthy pregnant patients that
Mhm.
we worry pass on those most likely ingrained bad habits to the
Mhm.
next generation. And the GLPs shouldn't I'm a huge GLP fan, I will say,
Okay.
but it
Okay.
shouldn't be sold as the answer
To
to
everything.
bad behavior, right? So we want people on GLPs that are going to then use that as a tool to help
Mhm.
get more energy, start being more active, learn what their body truly needs to function.
And I think too, when people can get, because I've watched people go on to them and lose weight and start to, like you said, have more energy, that inflammation is down. Like maybe they're sleeping at night because they needed a sleep apnea machine before because, that
Yeah.
was being impacted. And I have seen people start to have a little bit of new lease on life. Like, I wonder if it like helps to give them hope. Like, wow,
Oh,
like,
it's so we have, I mean, in our practice too, we do a weight loss clinic. regimen, where we do help women get insurance coverage of the GLPs. And my one nurse practitioner does a lot of it, and she gives stories all the time of women that be like, have changed my life. I have a new
Gives me
lease on life.
goosebumps.
And
Yeah.
so that's why, again, they have such a stigma too, but used correctly, like, right, you're 120 pounds and want to get down to 105.
Right. It's
And
not appropriate. Yeah.
that's not what we're using it for. But people that, sort of have something to say about women going on them for whatever reason, also perimenopause, menopause, it's harder to move that.
Yep. Oh,
Yeah,
yeah.
it's harder to be active. It's harder to, feel good or be a healthy weight. So there is a lot of research coming out using GLPs with HRT. So, and they've been medications that have been around for a long time
they're
too,
not
just
new.
like HRT. They were out when I was in medical school, which was a couple of years ago.
Just
So
a
the
minute.
class of drug is not new, which is another thing that people want to use as a fear tactic to shame people for being on them. Anyway, that was sort of a roundabout answer, but bottom line is GLPs are great. And I think that they're really helping women get healthier. And I'm hoping that it's being used appropriately with the education on how to eat and how to be active. So,
and I feel like that's good to know, because I think some patients are like, where do I go for that? Like, I don't want to just do some online plays.
right.
I want to work with a provider. And I think nutrition is a component of that. Nutrition, physical activity. Like, I try to teach, vacuum your house. If you haven't got a lot of steps today, vacuum the house, use the bathroom on the other side of the house if you work from home. Like, do things to get your steps in and just move your body, because we're not meant to be sitting in a chair all day. The most natural antidepressant you can do for yourself is moving your body. Activates all the feel good things. So mental health, you got to do it.
Yep.
That's huge. No,
It's just hard.
Sometimes it's hard. Don't get me wrong. I think some weeks are great. Some weeks are not. I have a gym in the basement. That's how I work out, because otherwise,
yes. Yeah, I'm talking some. Yeah.
My fiance, he's like great. He'll go all the time, but I don't have that much dedication. But if I can go in the basement,
it's important, so you do
it.
Well, and even little
3 days a week, 20 minutes. Yeah, it doesn't have to be crazy. It doesn't have to be like record setting. I'm not trying to enter a bodybuilding competition, but those compound weights, and if you're doing things for cardiovascular, even though at this point in time we're not really, right, we're supposed to be switching from the high impact, aerobic impact,
right? So longer, low impact cardiovascular workouts. So like your treadmill, uphill walking. That's what women are supposed to be
weighted vest,
longer after weighted vest stage. Exactly.
That girl in the neighborhood. Yeah, no, it's huge. So if patients wanted to reach out, and I feel like I have sent people your way, and they were like, oh my God, I got in, or I've got an appointment. So you're not scheduling crazy out to get in. Like I'm hearing stories about people scheduling a year out for menopause.
Oh gosh, no. I mean, even so, we have a menopause specialist in our office, which everybody should know. A gynecologist should be able to do your HRT.
Okay.
Right. So if you are talking basic hormone replacement therapy, and again, sometimes it can get nuanced. Sometimes people can dabble with things and want to really fine tune stuff. Then yes, maybe go see a menopause specialist, but you don't need to be, paying MIDI Health or any of these telehealth.
Out of pocket.
No, you can go to a gynecologist in the area. And if they don't do it, then you can also find another one.
I have like a list of people, whether I've seen it in mom groups, you're on there, people that I'm like, okay, here are some options depending on where you live. I know some people are like, if they live at the South Towns, they don't want to drive to Buffalo or whatever.
So I'm like, I can't possibly leave.
God, I can't go to Clarence. I'm in Orchard Park, right? Like,
right.
So I have like a list of providers that I will like share with people, because I think people need to know.
So, Michelle Adams, who has a pretty big following, she's in my office. So she she has a private practice where she does concierge, so longer, more nuanced, but she's also in my office and scheduling out, a few months for her.
Okay.
But you can always start with one of the other providers within my practice, me including, and I can get you started on something. And again, most of the time you don't need, sorry, Michelle, you don't need that specialty, right? You don't need someone that's doing stuff that's so
Like if you have
fine-tuned.
gut issues, if you've got like other issues, you're looking for that functional medicine that
if
is
you're
a little more
looking
in
for
depth.
that, she's there. Absolutely. And
Okay.
again, if you're looking for it to be in that long, she does concierge too. So she has her own private practice. But if
Okay.
you are just like, I need help and I need someone to listen to me, then
Mhm.
your gynecologist should be able to do that.
I mean, I have to say, when I started this journey and I was listening to all the podcasts because I was like, I'm sick of being dismissed and told, well, you're just in midlife. No, I'm fucking done.
And I want you to help me.
Yes. I wanted blood work. I ended up finding out because of my hysterectomy that I have PCOS, and I learned that in perimenopause. So, when your skin's breaking out wild like you're 12, I don't have like the overweight factor or the hairy face, but I have the cysts on my ovaries because we've done sonograms to look at those. And so I found this out when I started having issues. So it's like another layer of it. But the progesterone, I feel like that's been like life-changing, literally life-changing for my anxiety that nobody wanted to give me. I had to beg for it.
Yeah. Please just help me.
And
it's funny because again, I was begging people back in the day to go on stuff. So.
I wish my path had crossed with you,
I
sweetheart,
know.
But I like that you're open to having conversations with patients who have had hysterectomies. I mean, let me circle back to that. What are your thoughts when a woman has a hysterectomy but still has ovaries intact, or at least one ovary intact? What is your protocol for that? Like, what does that look like?
I mean, in terms of getting them started on HRT, that's actually because you don't, for the progesterone.
Yes. I was told I didn't have a uterus. I didn't need progesterone. But I was like, but everything I'm reading, this is really helpful with anxiety and I'm not sleeping.
Right. I mean, I would start someone with the estrogen just to see. So throwing everything, throwing the kitchen sink at someone, I also don't think is always helpful. Because what if you don't need that? But if you're come in and you get great results just with the estrogen patch or a gel or something like that, then great, we didn't need the progesterone. But yeah, we may end up adding the Prometrium at night to help sleep. And we do have a lot of patients that are on it without a uterus.
It's been life-changing for me. Like, my anxiety is like, move over Xanax. I have progesterone now in the house, which is a lot better for my brain as well.
Right. You can then function.
But that's first line of defense. Oh, let's throw some anti-anxiety meds at this woman instead of looking at her progesterone.
Right.
So, yeah, I mean, I think women sharing their stories and speaking up, what made you passionate about this?
We get to that. We all start to enter the age of things changing, and you want to be a champion for others that are going through it. So my patients have sort of grown up with me, right? So when I was a young, right out of residency, they were coming to see me, but now we've all kind of moved into midlife together.
Yep.
And so we're finding out our new selves and yeah, like I'm going through it, you're going through it. This is what's working for me. What do you want to, do you want to try the same kind of thing? So like I said, I was always very pro hormone, always. And so now it's more applicable because I too am in the land. Yeah.
Yeah. I mean, you've seen it when you have 15 years of experience, because I've seen that too with some pages that I've followed that I feel like I've unfollowed. Well, we don't have research on that. And I'm like, well, but you as a doctor are seeing how many patients a day? I don't know that you need to go out and get clinical research in a study. I'm pretty sure you've collected a lot of data working with so many women over time. You see it firsthand. I don't think you need to read a journal article.
Well, and that's where it goes back to that conversation, right? So we have our things that tell us like, okay, this is a big red flag. Don't do this because this could cause harm. But given that, you and I are not going to be treated the same way because you and I are not the same person. So that's where the articles stop, So we have those for our starting points, and then the rest of it then does become a conversation, like what works best for you versus somebody else.
And listening to your patients.
Yeah.
Awesome. So what would be, I know we kind of kept this all about perimenopause. That means I'll just have to have you back to talk about all the other things, but it's a big topic.
It's a huge, women's, it's great. It's exciting. It's, really being talked about more. There's so much misinformation out there that
What's some of the biggest misinformation? Because I feel like that's important to put out there.
I mean, I think the biggest one is really the young people with hormones. Like they don't want to be on them at all because they're like, it's going to cause infertility. Like we've had them since the 1960s. So
Yeah.
that's not the thing. So people are much unhealthier. So
Well,
again, that's one of my, and again, just because you know what path it's going to go down. You see the
and
writing on
people,
the
I
wall.
think another layer of this is chronic stress. Our lives are much more stressful than they were also maybe 50 years ago when infertility rates were maybe a little bit better. But chronic stress, I mean, think of animals in the wild, right? They can spontaneously abort if conditions become stressful, right? Like, why are we not thinking in terms of that with humans? Why fertility might be difficult if you're under chronic stress or not managing your shit.
Right. Well, and too, I mean, there's so many, we're getting pregnant older and there's just so many layers of it, but
There's a reason after 35, right? They call it
yeah.
a geriatric pregnancy. Is that
Yeah.
still relevant?
More 40. 40 is the new 35 now. Still
Okay.
might slap that diagnosis on, but I care way more at 40 than 35.
But there's a reason, right? Our hormones are
Yeah.
dipping
Yeah. Things are,
and
I mean, absolutely. But a 20-year-old that's not choosing to go on something that could potentially benefit them and let them reduce the anxiety of undesired pregnancy
oh God, yeah. Yeah. I love my
because of something
kids.
they saw.
Yeah.
And then OB has its own millions of misinformations out there. So like that's a whole
So what's
door
the
I don't want
difference?
to open.
OB is pregnancy and then GYN
Yeah.
is gynecological.
Just
Okay. Okay. I think I always say it together, but I feel like, right, it's
they
two.
do usually go together, but some
Okay.
people just practice like GYN now, but I do both. So but
Okay.
like I said, it's the misinformation is
Well, I think that's where you have to come in and put out the right information and continue to do that and share what you know so that there's some balance. And I don't know, I guess we live in a society too where people get on the internet and the first thing they say, oh, it must be true because I saw it on TikTok. Well, no. Ask questions, be a critical thinker, think outside
yes.
the box a little bit. You
Critical
know,
thinking.
we're lacking that. I hate to say that,
Just
but
question what you're seeing in everything. Question your doctor. I mean,
yeah.
it's fine. Say, how do I know that? Why do you, I'm not looking for you to take me at face value either. But at the same time, have a healthy dose of skepticism with everything.
And I'm gonna say this because people do this too. Oh, I got on my chat AI or whatever, and this is what it says. Well, the internet can be wrong. I just want to point that out. When I plug my
Yes.
name in for my podcast, someone else's podcast pops up. It's not correct all the
Right.
time.
Right.
So,
Right.
do research, yes, but have conversations and
Yeah.
ask the questions
Yeah.
for
Yeah.
sure. Awesome. So, what would be your parting words? Like, what would you like to leave for patients or women, clients who would be like interested in exploring more about perimenopause?
I think open a conversation and the biggest thing for me is if you don't feel comfortable with your provider opening up a conversation and having a talk about how you feel and what your needs are in life, or you feel dismissed if you do that, then as scary as it is and as hard as it is to
Hmm.
find a new provider, they are out there. There's a lot of us that care. There's a lot of us that want you to feel better
Good.
and to enjoy, act two of life.
Yeah.
So don't be afraid to make a change. And I think, so many people stay in a bad relationship just because it's the path of least resistance sometimes. But you know what? If you find yourself someone that's willing to listen, it can be a game changer.
Be
So
willing to make the change. I think that's not every OB, like you said, they're changing. There's
right,
faces
right.
changing as times change, as more information comes out. Not every OB wants women's wellness, and that's their thing, and that's okay. I think you got to find a provider who's
Yeah.
willing to explore that with you.
And you don't need to pay a ton of money on some online whatever. You can if that's where you feel comfortable,
Of course.
but we also can do that. So your hometown OBGYN does have the training or should feel comfortable getting you started on HRT.
Perfect. I love it. Awesome. Well, thank you for joining me. I really appreciate this. and all the information that you have on this topic, because women need to hear it, and I'm going to be screaming it from the rooftops. So awesome. Thank
I'm
you so
screaming
much.
a lot of things, so it'll be one of the other things that
That's
I'm always
okay.
screaming.
That's okay.
Thanks for having me.
Thank you
And
so
I know you got to
much.
get to a soccer game. So,
I do. But thank you. It was wonderful talking with you, and I look forward to talking with you more.
yes, talk to you
Awesome.
soon.
The views and opinions expressed by today's guest are her own and do not necessarily reflect those of Mindy Lapazetta, LMHC. This episode is intended for educational and informational purposes only and explores different perspectives on healing and personal growth. It's not a substitute for medical or mental health treatment. Always consult with your own qualified healthcare or mental health provider regarding your own individual needs. Listening to this podcast does not establish a therapist-client relationship with Mindy Lapazetta, LMHC, or any guest featured on the show. If you're experiencing a medical or mental health emergency, call 911 or seek immediate assistance.